Good morning. So today we are going to discuss about drug excretion. Myself, I'm Dr. Monica, Assistant Professor, Department of Pharmacology from Sree Balaji Medical College. So today this topic is coming under the new CBME curriculum. So under the PH 1.4, that is so to describe about the drug absorption, distribution, metabolism and excretion. So excretion is a part of pharmacokinetics. Okay. So today's take-home message or the learning objectives for the today is we are going to discuss about the various methods of excretion and its clinical significance. Okay. So the introduction for today's classes. So we have to know the difference between elimination and excretion. So elimination is nothing but includes the drug metabolism plus the excretion. That is, a drug must get broken down and it gets excreted. So this metabolism plus excretion is called elimination. Whereas the excretion alone is called as a process in which the body must get rid of the drug. So this is the process called excretion. So coming to the introduction of excretion. So there are four components of pharmacokinetics: absorption, distribution, metabolism and excretion. So previously it was absorption, distribution and metabolism was discussed, and today we will be discussing about excretion. So excretion is nothing but a process by which the body gets rid of the drug or its metabolites. So as a rule, a polar, water-soluble and ionized compounds will be eliminated. They does not cross any membrane, and non-polar substances and lipid-soluble and unionized drugs will get reabsorbed and crosses the membrane. So coming to the routes of drug excretion, we have two routes, major routes and minor routes. So major routes include kidney, biliary, pulmonary and fecal route of excretion, whereas the minor routes include breast milk, skin, hair, sweat and saliva. So coming to the renal excretion. So we have three main processes involved in the renal excretion. So as we know, the nephron is the functional unit of kidney, and there are three main processes happening, like glomerular filtration, active tubular secretion and passive tubular reabsorption. So in the glomerular filtration, the drugs, generally the renal artery carries the blood, and the blood goes to the glomerulus, is nothing but a tuft of capillaries, and from the glomerulus it get filtrated it goes via the Bowman's capsule. It is a sieve-like structure where it allows the filtrate to enter the proximal tubular lumen. And here, so not all the drugs is going to, all of which is not going to pass by. So we see here, smaller molecules will pass more easily via the glomerular filtration. Whereas if the compound is having larger molecular weight or it bound to the protein, then it cannot pass via the glomerulus. So what are the things that's governing, factors that are governing the glomerular filtration? Is molecular size. The compound must be, if it is more than 20,000, it cannot be filtered. And when the drug is plasma protein bound, it cannot be filtered via glomerular filtration. And if the renal perfusion is better, then faster removal will be there. So these are the three main parameters for glomerular filtration. So coming to tubular secretion, So in the glomerular filtration, 20% of the drug can get excreted, whereas in the rest of the drug, how can it get excreted? Is it will just pass on the whole. The nephron is having a good blood supply, where the rest of the drug will be secreted via proximal tubule. So in the proximal tubule, there is two energy derived carrier mediated transport systems, and these transport systems are non-selective, and it is one is for acidic drugs and one is for basic drugs. So here the protein binding is not a problem. So acidic drug carrier system, in examples for that is the penicillin, salicylic acid, thiazide diuretics, probenecid, indomethacin, sulfonamides, and the endogenous compounds like uric acid. So all these uses the acidic drug transporter system, and certain drugs like morphine, quinine, neostigmine, procaine, atropine, endogenous compounds like dopamine, choline, histamine. So all these uses the basic carrier system. So here, so this carrier system is like have like a small door. So where 10 people are there, only 3 people can pass through. Then what will happen? Whoever is strong will cross and get outside, right? The same way here also. These particular carrier systems are non-selective. So only one drug can use at a time. In that case, so if two similar acidic drugs or two similar basic drugs, if you are giving, so two drugs with same physicochemical properties if given, then whichever is having a greater rate of excretion will go fast, retarding the other drugs. So what happens? This results in increase in duration or prolongation of action of the drug which has been retarded back, right? So for example, so this can be beneficial in certain cases and harmful in certain cases. So the examples are, one can be beneficial and it can also be harmful competition. So coming to beneficial competition, probenecid is a uricose-uric drug given for the treatment of gout, whereas penicillin, amoxicillin are the group of cell wall synthesis inhibitor antibiotics. So these, when taken together, what happens is this probenecid is going to inhibit the tubular secretion of penicillin and amoxicillin. So in that case, the penicillin will stay back in the systemic circulation, and this causes increase in plasma half-life of penicillin. So it is beneficial so that because the penicillins and amoxicillin generally have shorter half-life, when we give along with probenecid, the half-life of penicillin will be increased, so duration of the drug will also be increased as well. So when it is harmful, so here examples are, so when a weakly acidic drugs like lactic acid, salicylic acid, so these drugs are given, so it interferes with the secretion of endogenous substances like uric acid. So uric acid has to be excreted. When it is in the secretion is inhibited, there will be accumulation of uric acid in the body. So this will cause this will cause gouty arthritis. So coming to a second example is probenecid inhibits the renal secretion of nitrofurantoin. So this nitrofurantoin is an urinary antiseptic which is going to be helpful in case of UTI and is going to get concentrated in the renal system. So then it is going to act there and prevent the infection. So now this probenecid is going to inhibit the secretion of nitrofurantoin. So nitrofurantoin cannot go into the to its target site. So when it cannot reach the target site, then the efficacy cannot be there. There won't be zero efficacy, right? So and nitrofurantoin has nothing to do with any systemic conditions as well. So in this case, the duration of UTI will be prolonged, and in we have to change with the medications. So coming to the tubular reabsorption. So reabsorption generally is a process where the body does to conserve the nutrients like sugar and electrolytes and all. So it generally happens passively in the distal nephron, and this reabsorption is depending on lipid solubility, ionization constant of the drug, that is pKa. So pKa is the pH at which 50% of the drug will be ionized and 50% will be unionized. And also the pH of the urine. So as a rule, all acidic drugs will be non-ionized, and all acidic drugs are will be in non-ionized state and get reabsorbed. Whereas the quaternary ammonium compounds and aminoglycosides are highly polar and they are not reabsorbed. So normal urinary pH is slightly acidic. So in case of acidic drug poisoning, if the acidic drugs will get unionized, will be reabsorbed more. So we have to alkalinize the urine and with soda bicarbonate or sodium citrate, so that what happens is the acidic drugs get ionized in the urine and get excreted. So example, salicylic acid and barbiturates poisoning. So we were same like in weekly basic drugs like morphine and amphetamine. So in case of morphine and amphetamine poisoning, so the urine is made slightly acidic, right? So if it is made slightly acidic, then these basic drugs will get ionized in the acidic pH and get excreted rather than reabsorption. So moving on to the biliary excretion and enterohepatic circulation. So this biliary excretion, the drugs carried in the plasma enters the liver, and from the hepatic cells there will be hepatic transporters. From there it enters the bile, and from the bile it enters the intestine. So from the intestine, certain drugs which are water soluble will just get out via fecal route, whereas lipid soluble drugs and drugs with drugs which are non-ionized will enter the plasma again and goes into the same circulation. So this is called as an enterohepatic circulation. So this enterohepatic circulation generally prolongs the drug action because it keeps instead of excreting, it keeps in the circulation for a longer time. So example is quinine, colchicine, D-tubercurin and corticosteroid and erythromycin. So coming to the clinical significance of this, so digoxin and vitamin D3, indomethacin, so all these drugs get reabsorbed from the gut through enterohepatic circulation. So the duration will be prolonged. So certain drug metabolites from the bile to intestine, it reaches the intestine, it gets deconjugated or hydrolyzed. So it will be releasing its parent drug again. So this parent drug again gets absorbed into the systemic circulation, prolonging its half-life. So example is thyroxine, morphine, chloramphenicol, tetracycline and ethinyl estradiol. So basic drugs like morphine poisoning, generally the gastric lavage is advised. Why? Because basic drugs will in the intestine, the pH will be slightly basic. So there will be enterohepatic circulation and there will be more toxicity, right? So gastric lavage is very important in basic drug poisoning because this will wash out most of the drugs. So coming to pulmonary excretion. So gaseous and volatile substances generally get excreted via this route, and factors affecting this pulmonary excretion are mainly pulmonary blood flow, rate of respiration and solubility of the substances. So here the partial pressure of the blood will be the governing factor, and so around 1 to 10% of alcohol which has high solubility in the blood and tissues are excreted slowly by the lungs. So eucalyptus oil and garlic oil are eliminated through expectoration. Coming to fecal route of excretion, here orally ingested drugs which are not absorbed get excreted via fecal route, and drugs which are excreted through bile and are not reabsorbed from gut are excreted through fecal route. So examples are for orally ingested drugs which are not absorbed are magnesium sulfate, streptomycin, neomycin, bezitracin, purgatives. Whereas the drugs excreted through bile and which are not reabsorbed are erythromycin and corticosteroids. So coming to excretion through breast milk. So it is very important because certain drugs, when it enters in the breast milk, it will cause unwanted pharmacological effects in infants. So this how it is entering and all depending on the pH partition principle. So here the basic drugs so will be non-ionized at the basic pH, right? So our plasma is slightly alkaline pH. So we can see that the plasma pH is 7.4, it is slightly alkaline, where the basic drugs will be non-ionized. So it will be ready to shift the diffuse through the mammary epithelium and gets accumulated in the breast milk. So, and this breast milk is slightly acidic. So what happens here? So when it is acidic in nature, because of its acidic in nature, the basic drugs get trapped here. So this is called as an ion trapping. So when the acidic drugs will cross the barrier when it is in acidic environment, basic drugs will cross the barrier in the basic environment, but opposite cannot occur. It will get trapped. So acidic drugs, so when the basic drugs enter the breast milk, it becomes ionized and cannot come back. So here this will cause unwanted pharmacological effects in infants. Apart from this, ethanol and urea enter the breast milk readily, which are independent of pH. So clinical significance of this are so certain basic drugs like chloramphenicol tetracyclines, ergots, morphine, metronidazole, bromocriptins, OCPs, purgatives, and antihistamines. So these cannot be given, they must not be given to lactating women. And certain acidic drugs, which are though less secreted, may cause serious adverse effects. Like sulfonamide, they may cause kernicterus and allergy. Penicillin may cause allergy. Ampicillin will cause diarrhea. Dapsone may cause hemolytic anemia. Phenobarbital will cause drowsiness. Phenytoin may cause methemoglobin and hemoglobinemia. And theophylline will cause restlessness. So all these drugs, though it is secreted less, it may cause serious adverse effects. So all these drugs should be prevented, must not be given to a lactating mother. Whereas drugs causing hemolysis are chloramphenicol, chloroquine, primaquine, quinine, quinidine, procainamide, nitrofurantoin, naldexic acid, dapsone, isoniazid, probenecid, and cotrimoxazole. So all these drugs must be prevented, must not be strictly, should not be given to lactating mother. So coming to salivary excretion, pH of saliva varies between 5.8 to 8.4. So now unionized lipid-soluble drugs are excreted passively here. So examples are caffeine, phenytoin, theophylline, iodine, and potassium iodides and lithium. So coming to excretion through skin, hair, and sweat. So here griseofulvin is secreted in the skin. Arsenic, mercury salts, and iodides are secreted in the hair follicles. Amines and urea are secreted in the sweat. So to summarize today's class, drug excretion is a process by which the body gets rid of the drug as well as its metabolite. And we have two routes, major routes as well as minor route. And a renal route of excretion is very important out of all. And next is biliary route of excretion. And third one is pulmonary route of excretion and fecal route of excretion. Apart from this, we have minor routes, that is sweat, skin, saliva, and breast milk. So coming under the renal route of excretion, we have glomerular filtration, tubular secretion, and tubular reabsorption. So not all the drugs pass by through glomerulus. So only the drugs which is having less molecular weight, that is less than 20,000 generally, will pass through by glomerulus, but more than 20,000 cannot pass. And when the drug is plasma protein bound, it cannot pass through the glomerular filtration. And the third checkpoint is the renal blood flow must be very good. Next is the tubular secretion, where we have two type of transporters, both acidic as well as basic transporters, that carries, even though the larger molecular weight and the protein binding is not a problem here, so it is going to get secreted inside the proximal tubule. Whereas in the reabsorption, the drugs which is more lipid soluble will be reabsorbed better, and if the drug is non-ionized, it will be reabsorbed better. So coming to the biliary route of excretion, the drugs will be carried through via transporters in the bile to the intestines, and from the intestine, those which are non-lipid soluble and not ionized will directly excreted in the feces. Whereas certain drugs which is more lipid soluble and which is non-ionized, these will cross the barriers and it will go back again, it enters the systemic circulation, and there will be an enterohepatic circulation. So this enterohepatic circulation will cause prolongation of drug action. Okay, so the third route is pulmonary, and the pulmonary route of excretion we commonly see is the most gaseous and volatile compounds will get excreted, and 1 to 10% of alcohol will directly get excreted via pulmonary route. So in the feces, those which as we already discussed, from the those which comes from the bile, it will directly get excreted, or certain drugs which won't get are reabsorbed or absorbed in the intestine will directly get excreted through feces. So other routes are minor routes, and other important point is ion trapping. So ion trapping, the concept is nothing but those drugs which are having the same physicochemical properties. That is, if the acidic drugs will get better absorbed in the acidic environment, whereas if it's the basic drug, will get better absorbed in the basic environment. If it is not, then if the acidic drug will be better absorbed in the acidic environment, and when it goes to a basic environment, there it will get again reionized and get trapped there. So from there it cannot move. So this is called as an ion trapping. So then this basis is used in case of poisonings. So in case of acidic poisoning, we will be alkalinizing the urine so that the acidic drugs get trapped in the lumen and cannot be reabsorbed back. Whereas in case of alkaline drug poisoning, we will be acidifying the urine so that the alkaline drug will be getting ionized there and will get excreted. Thank you.